So I'd like to introduce Dr. Chin. Everybody knows Dr. Chin, and she is one of our lecturers in internal medicine and has been around almost as long as me. But she's here to talk about technology use among students and faculty of UWI.
How do I get it up? Thank you for inviting me to speak about our survey, which was to assess the existing patterns of experience and attitudes of students and faculty members of our school here in Nassau, Bahamas, with regards to the library resources and information and communication technology on personal devices. We were going to use this data to assist in the development of policy and strategies for teaching and learning. So as you know, information and communications technology is an integral part of our daily living globally. In the US, there are over 184 million smartphone users now, and it's predicted to grow to about 220 million by the year 2018. In 2009, there were 64% of American physicians who had smartphones, and 84% of them were using them for work by the year 2015. As of 2012, in the Bahamas, we had 30,000 people having data plans with BTC. But however, there are no statistics for healthcare workers and their use of electronic devices in the practice of medicine in the Bahamas. Investment in costly technology needs to be evidence-based for smaller, not-for-profit institutions like our school to keep up with the rapidly changing advances of the modern world. So what we did was we administered a cross-sectional survey, which was offered both in print and online during the months of January to June of this year, and we sent it around to the faculty, the undergrad students, and the postgraduate students. Of the 249 potential persons, we had 155 participants for a 62% response rate, of which 60% were females and 40% were males. Approximately 36% were faculty, 35% postgraduate students, and 30% undergrad students, and approximately 60% of them were fourth years and 40% were fifth years. The majority, 69%, were in the 20 to 40 year age group, 19% in the fifth decade of life, and 12% were in the older age group. All participants had their own laptops and smartphones. 97% of them had tablets, and 84% of them owned or had access to a desktop computer. Of the desktop computers, 81% of them were Windows-based. Almost 50% of them, of the tablets were iPads, and 50% of smartphones were Android-based, and about a quarter were iPhones. About 2/3 of the laptops were Windows-based, and the rest were Apple computers. 3/4 of participants would bring their laptop and their tablet regularly to work or to class. However, an overwhelming majority of participants, 77%, did not use or hardly use the library resources, with only 5% of participants using the library daily and only 17% weekly. 28% of participants say they were proficient in using the library's resources, while 83% was self-sufficient in using statistical programs, and 97% were versatile with the PowerPoint program. When we looked at resources that were rarely or never used, you could see that e-journals and at the top and library subscribed databases were only about 50% used, while 64% hardly ever used a virtual learning environment, which Dr. Mahiz will soon speak about, and a good percentage, over 70%, did not blog or tweet or use e-portfolios. For daily smartphone usage, 83% used instant messaging like WhatsApp daily, the camera, and social media like Facebook are about 50%. 1/3 of people would listen to music, and 28% use their smartphone for news, and less often for weather, games, and driving directions. 65% of participants use their cell phones for making online long-distance calls and making travel arrangements, while 58% would shop online and 48% would be paying bills, and less people would be using for cooking, with recipes or podcasts or personal camera monitoring. With regards to the medical apps, though, and websites, you could see that Hippocrates and Medscape are the more popular programs. Textbook and tests and management reference apps were less often used, and reading the New England Journal of Medicine online was dismal at best at 27%, and Skyscape and Micromedics, which are paid apps, are much less used. With the last set of data that we will discuss today, we asked about distractions caused by smartphones, and you could see about 50% of participants said that they were distracted at least once per hour. And if you look at them, 39% forget what they were doing at the time. They'll forget the task at hand. So in conclusion, 100% of participants had smartphones or laptops, and most were using them for personal use and sometimes work-related use. The use of virtual learning environments, Twitter, and other learning apps were presently low. Very few people used valuable library resources regularly. So there's much that we could gain by recognizing and using more medical apps and providing more learning opportunities online. So our first recommendation will be to make learning and clinical references more available and accessible, and by providing access to apps, especially medical apps, databases, software like electronic medical records, and hardware not just on campus but also in the hospital and in clinics. Our second recommendation would be to provide Wi-Fi throughout the hospital, throughout the clinics, the UWI campus, and have interconnectivity of hardware. And thanks to Dr. Halliday, we do have Wi-Fi in here for you today. They also recommend 24/7 study groups that some of the students were suggesting, and not necessarily in the library. We should also provide a list of useful apps, websites, online databases, and e-journals available to each department. And our last recommendation is to provide online courses and lectures through a virtual learning environment, which we'll hear about in the next topic. So just to remind you, the Chinese proverb that says, "Do not confine your children to your own learning, for they were born in another time." And John Dewey said similar. He said, "If we teach today as we were taught yesterday, we rob our children of tomorrow." And then Heidi Hayes Jacobs, who's an educational consultant, said, "Teachers need to integrate technology seamlessly into the curriculum instead of viewing it as an add-on, an afterthought, or an event." Thank you for your attention. And over to you.
Thank you, Dr. Chin. Very timely. Are there any questions for Dr. Chin? No. So, Dr. Chin, do you have any idea what the cost would be, Dr. Chin, what the cost would be to actually supply free internet access so that we can get it throughout the hospital for the students and the...
We didn't look into any costing or economics, and that would be the next study.
Because I was going to pass that on to Dr. James Johnson, who is right here as our chief, to try and get that implemented
That would be very
ASAP.
good.
Okay, so that is a tall order for Dr. Johnson. Are there any other questions? Dr. Barrett?
I use a free electronic medical record at my office right now. It's called Practice Fusion, and you could download it onto your laptops, and it's available on your phone, on my phone, so I could access it anywhere in the world.
Any other questions? And I do agree with your Chinese proverb. I thought that was very timely. Thank you very much. Let's give another round of applause to Dr. Chin. Our next speaker is Dr. Sherilyn Hannah Mahace. And Dr. Hannah Mahace was our first director for the family medicine program, and in fact is now our deputy medical chief of staff for the hospital. And she's been very instrumental in stimulating research with the family medicine persons, and you see that yesterday, a lot of the talks that we had presented were from the Department of Family Medicine, so she and her department are to be congratulated. So today she's going to be talking about exploring personal and institutional concerns regarding the use of virtual learning environment. Let us welcome Dr. Hannah Mahace.
Thank you, Dr. Sinqui. It's indeed an honor to be able to present this small study that I did as a part of my master's in the medical education leadership. In July of 2012, a process of commissioning a research and education network by the Bahamas government began with a partnership with CaribNet, in keeping with United Nations Sustainable Developmental Goal number 4, which was inclusive and equitable quality education and the promotion of lifelong learning opportunities. The University of the West Indies School of Clinical Medicine and Research was invited as a stakeholder, and this would result in a virtual learning environment that was shared by regional research and educational institutions. It was expected to provide access to cost-effective, high-quality e-learning content from around the world. And here at our school, our teaching and learning environment entails face-to-face learning for both clinical and classroom teaching. But of course, our environment is changing. We've expanded admissions at SCMR. And of course, we need to keep pace with new materials. We need to keep pace with learning tools. And so in preparation for a larger scale virtual learning environment, I proposed the introduction of a course management system, which is web-based, and it provides several advantages: virtual access to classes, class content, discussions, homework, quizzes, grades, and assessments, and it supports the technology for both synchronous and asynchronous learning. It can decrease costs, increases accessibility, provides flexibility to an anytime, any place, anywhere learning. So that the success of the introduction of a virtual learning environment depends on several important factors, such as the user's characteristics, their needs, goals, motivation, their abilities and talents, their acceptance and use, and of course, cooperation from the curriculum developers, teachers, students, as well as technology specialists. So my question was, what are the perceptions and personal concerns of the potential users on the use of a virtual learning environment for teaching and learning? In the medical literature, a review showed that there were several perceived barriers on the adoption of e-learning. Some of them I've highlighted here in terms of categorization from internal source barriers, external learners, teachers, as well as curriculum. Things such as the quality of the e-course, access to the students, concerns about workload, financial, assessment of progress, the lack of adequate knowledge about e-learning teaching environment, and of course quality and resources as it relates to the curriculum. There were also categorization in terms of interpersonal, institutional, training and technology, as well as cost-benefit analysis. And particularly the institutional, lack of policies or standards, lack of control over property rights, lack of faculty involvement in course decision-making, and of course, online work that's not valued for promotion and tenure. The Stages of Concern questionnaire was the instrument that I found in the literature review that was based on the change theories of the concerns-based adoption model developed by Hall and others at the University of Texas at Austin in 1987. And this model was based on research with student teachers who went through developmental stages and expressed concerns at each stage as they learned to teach. This was piloted and validated, and the 35-item questionnaire was then used in 11 longitudinal cross-sectional studies showing moderate to high reliability and coefficient of internal reliability ranging from 0.6 to 0.87. So in the description of the stages of concern in this questionnaire, there were 7 stages ranging from 0 to 6, so 7 overall, and these were actually further categorized into self-based concerns, the first 3, task-based, related to management, and impact-based, which was the last 3. And statements on the stages of questionnaire in the 7 stages ranged from stage 0, where I'm not concerned about the virtual learning environment at this time, to 6 of I now know of some other approaches that might work better. So this study was a qualitative design using this 35-item questionnaire with a Likert scale ranging from 0 to 7. And 3 open-ended questions were added that looked at what the concerns were about virtual learning environment for teaching and learning, any significant barriers, and how the virtual learning environment may be useful. All postgraduate students, faculty, and 3 administrators were invited by an online invitation between February and March of 2016 to participate. These persons were further categorized, postgraduate students according to their year, the faculty according to their department, and years of experience. The responses were sent back electronically. These were analyzed and scored using the University of Texas at Austin system. The raw scores were calculated for each of the 7 stages, and mean scores were determined. These were converted to percentile scores and then plotted on a profile chart. And the interpretation, these were downloaded and interpreted according to the effective stages of concern, and the open-ended questions were coded, and themes were then developed around the group's concerns. So this shows the typical non-user profile, where with the introduction, the early introduction of a new innovation, there are very high self-based concerns, which is our stages 0, 1, and 2, and then less concern in terms of task-based, and even less in impact-based in 4, 5, and 6. This was approved ethically both locally and internationally. 22 postgraduates, 32 faculty, and 2 administrators, a total of 56 persons responded to the online invitation. So what were the results? The group profile fitted that of the typical non-user, where we have very high self-based concerns in stages 0, 1, and 2. The group had very little concern about their involvement with the virtual learning environment. They wanted to know more information, and they did have concerns about the demands of a virtual learning environment and the adequacy to meet these. Management concerns were less intense, and they were more about being able to manage all that the environment would require and not having enough time to organize themselves. Concerns on consequence for the students was lowest among the group, and there were less concerns on collaborating with others and having any potentially competitive ideas. This particular slide I wanted to show on the profile of the UWI faculty, and we see that those faculty who were most experienced, 21 to 30 years, I wish I had, it's the teal-shaped graph that goes up there, showed that they had very intense focus on collaboration and coordinating with others in the use of the environment. And the 5 to 20-year experience also had a focus on ways to reap more from the virtual learning environment, possibly even making changes in terms of replacing it with a more powerful alternative. So gave the impression that these persons were more familiar with the virtual learning environment and would have had some experience with it previously. This profile was also interesting of the postgraduate students. We see that those in year 2 had very high concerns about the consequences for them as it related to the impact on their immediate sphere of influence, their relevance, the relevance of this innovation for them, their evaluation of outcomes, their performance and competencies. And there was also a focus on collaboration and coordination with others in the use of the virtual and learning environment, as you can see much higher in that blue chart there. So what about the open-ended questions? So those 3 questions that was asked, 56 responses were coded for each of the 3 questions, and these were subdivided into concerns and barriers, and then themes were developed. And we see under the concerns the group had were mainly about technical support, internet access, efficiency and accessibility, the loss of face-to-face teaching, time management, adaptability, equity, implementation timeframe, and cost. And so 4 themes were actually developed as a result of this: training and technology, interpersonal, institutional, and cost-benefit analysis, and the same for barriers. When we looked at the themes on the usefulness of the virtual learning environment, again, 4 themes: time economization, flexibility of teaching and learning, facilitation of teaching and learning, and information sharing. So in conclusion, the administrators, faculty, postgraduate students fit a typical non-user profile for the early adoption of a new innovation with very high self-based concerns and lower task and impact-based concerns. Overall, it was a positive profile for a group who's interested, they wanted to know more, and was willing to give input into developing a better product that is both useful and productive. And the institution is receptive and had fewer concerns and barriers. So the concerns-based adoption model was useful in determining the personal concerns, barriers, and usefulness for our faculty, postgraduates, and institution. Adequately addressing these factors is critical in further planning and development of a virtual learning environment for teaching and learning. So these results encourage a process of planning for implementation of a virtual learning environment with a team that should include representatives from postgraduates, particularly our second years, faculty, administration, IT, and curriculum developers. Key stakeholders should review this study and develop a phased plan of implementation to ensure a smooth transition in our organization's culture. And once implemented, further studies can be continued using this concerns-based adoption model to determine the concerns with use of the virtual learning environment over time. And this information adds to the research literature both regionally and internationally on personal concerns, barriers, and usefulness of a virtual learning environment. I would like to acknowledge my research advisor, Dr. Broyles, and I thank you for your attention.
Thank you very much, Dr. Hannah Mahes. Are there any questions for Dr. Hannah Mahes? No questions? Oh, okay. I have one. Okay. All right. You are right on the backbone of Dr. Chin's talk, and I just wonder again if you explored the cost of trying to implement a VLE, and you are very well positioned, along with Dr. James Johnson as his deputy, to bring this to fruition.
Yes, as part of my program, I did look at the cost, and there are several platforms available, particularly the Moodle, which is actually, it's a free open software that can be used, which would really reduce the cost. And I have been in contact with the IT for the Public Hospitals Authority in possibly bringing that particular platform that we can start to introduce the cost management software that we can use at a basically no cost to us, so we're looking at that.
Okay. I'd also like to put a plug in for Dr. Halliday, too, who really has spent a lot of time to develop the IT support for this conference. He also has designed and put together something, and he's really been very cost-effective too. He must be Chinese, right? But because he's really looked at all of the implications for costs to the university and tried to put together something that is a lot of money elsewhere. And in doing so, he is starting to have where we can do the MCQ examinations on the computers, right inside the library, on the personal computers, without having to worry about the security of the computer. So I do congratulate him, and I did post a comment to the blog for the conference to say that he's brought us into the 21st century, and this is about time. So, you know, I would like to give him a special round of applause for that. And again, another round of applause to Dr. Hannah Mahase as well for her talk. We did make another change with the keynote speaker. So we have Dr. Nikia Forbes is going to be presenting the keynote address for this session. And Dr. Nikia Forbes is actually a graduate from the University of the West Indies, started out in Trinidad. No, Mona, Dr. Forbes? Trinidad, right, Trinidad. I was fortunate enough to be one of her tutors, so far back, and watched as she went back to Mona to do her postgrad in internal medicine, and then was able to engage in a fellowship program organized with collaboration with University of the West Indies. I can't remember the name of your, but you can announce that one for me, please. And we were able to do a fellowship program for infectious diseases. So I'd like to welcome Dr. Forbes, who has now been able to position herself to replace Dr. Perry Gomez, who was our infectious disease specialist here and has moved on to greater heights. Dr. Forbes?
Good morning, Dr. Singui. Good morning, everyone. Thank you for that kind introduction. I look forward to sharing with you a bit on our local epidemiology on the rise and fall of HIV in the Bahamas. So I will share with you the introduction and background of our epidemic and our local epidemiology and statistics. I would really like to reference how this relates to the global situation relating to HIV and AIDS in the Bahamas. Professor Stan Rude and I planned our presentations to really complement each other, and so I will share with you our local data on the HIV continuum of care and exactly what it is that we've done to try and make an impact in the epidemic in terms of antiretroviral therapy guidelines and coverage, as well as the challenges that we still have and the way forward. According to UNAIDS, 36.7 million people are living with HIV worldwide. In 2015 rather, based on the UNAIDS fact sheet, 2.1 million new infections occurred, and there were 1.6 million deaths. Of the number of people living with HIV and AIDS, you will see that not all of them are accessing antiretroviral therapy. 17 million, in fact, are accessing antiretroviral therapy, and that is 46% of all adults living with HIV and 49% of all children. New infections have fallen by 6% globally overall since 2010, and AIDS-related deaths have also fallen by 45% since the peak in 2005. As it relates to HIV in the Caribbean, regional data suggests that the Caribbean is particularly affected by HIV and AIDS, with very high rates, second only to sub-Saharan Africa. The UNAIDS announced that 2 million people were living with HIV in the Caribbean in 2015. There were 100,000 new infections and 50,000 AIDS deaths. For those that are visiting our shores, welcome. The Bahamas is an island nation of more than 700 islands. We have a total land mass of about 5,382 square miles, but this is actually scattered over more ocean than there is land. It's scattered over 80,000 square miles of ocean. And according to our census population projection, there was a total population in the Bahamas of just under 370,000 persons in 2015. The Bahamas, however, has a very high rate of HIV. It has the highest rates of HIV in the Caribbean. This is a slide that will show you what the number of persons living with HIV and AIDS are in some Caribbean countries. And you will see that the Bahamas had, in 2012, about 7,000 persons living with HIV, and the adult prevalence was 3.3%. Now, this isn't the largest number of persons. However, the adult prevalence rates were quite high. I will now share with you our local epidemiology on how the epidemic of HIV unfolded in the Bahamas. So the first case of HIV was actually a clinical diagnosis. It was a migrant female with pneumocystis carinii pneumonia. And she was clinically diagnosed with AIDS in that she also had wasting. And she also had a rash. When the serum was tested for this patient, she was indeed confirmed to be HIV positive, and the serum testing by HIV ELISA was introduced in the Bahamas in 1985. And as a result of seroprevalence studies in 1992, Professor Stan Reed alluded to that yesterday in his talk, all public health clinics then provided counseling and HIV testing with consent in the 1990s. This graph will show you the number of new HIV diagnoses, including AIDS, at the first diagnosis in the blue line. So here, corresponding in the tables, we have the years from 1985 to 2014. So we do report on our HIV epidemic yearly, and we follow the patients for a one-year period. So our most current data is up to 2014. We would have followed those patients up to 2015, and then we shall do that again at the end of this year for 2015, and so on going forward. So you will see that in terms of the new diagnoses, these rose steadily to a peak in 1994 of 805 patients, and it has been steadily declining. And I'll share more with you on some of the interventions on why this has happened. In 2014, we reported a low of 267 patients versus the peak in 1994. Why is it that the Bahamas has such a high rate of HIV and AIDS? Well, there are several things that have been observed. The Drug Enforcement Agency of the United States published in their history book that in the early 1980s, there was an epidemic of cocaine being shipped from South America to the United States. And the Bahamas was actually a central point, a hub for the distribution of cocaine. And so as a side effect of that process, there became an availability of locally available cheap cocaine, crack cocaine, that was cheap, smokable, and easy to use, and caused a very fast high. Some members of our local population also then developed a drug habit of using crack cocaine, and I will then allude to this study that was done by my predecessor, Dr. Perry Gomez, as well as Dr. Orlando. He's also a cornerstone of our HIV response here in the Bahamas, on a study that was published in the Journal of Sexually Transmitted Diseases in 2002, entitled The Epidemic of Crack Cocaine Use, which was linked to epidemics of genital ulcer disease and heterosexual HIV infection in the Bahamas, and how this impacted prevention and control measures. So it was a retrospective case control study of cocaine use and sexually transmitted diseases. They looked at ambulatory visits and inpatient admissions for cocaine use and noted that it peaked between the years 1984 to 1987. And genital ulcer diseases increased 12-fold in the Bahamas during that same time frame and then declined. And as well, cocaine use was seen among patients, and they significantly had more STDs, especially genital ulcer diseases, and secondary syphilis, which is a genital ulcer disease, and HIV infection. And when we consider the virology and the pathophysiology of how these diseases are transmitted, with a genital ulcer, that increases the risk of HIV transmission, and we know that in terms of behavior, certainly cocaine use and other substances can disinhibit behavior and lead to risky behavior, situational sex for secondary gain. And so it is proposed that that may be why the Bahamas had such a high rate of HIV, but we also had large testing, so maybe we were diagnosing more than some other countries. In terms of the timeline of our response, in 2001, the program was expanded And the professor alluded to pregnant women offered zidovudine monotherapy and then triple therapy later on that same year. And then our response was enhanced as well, so that we had a local national HIV/AIDS center, which is really the action arm of our framework. And triple therapy, or combination antiretroviral therapy, was offered to some persons, and that was helped by the Clinton Foundation, which was able to broker low-price generic quality medications that could improve antiretroviral therapy coverage, in that antiretroviral therapy can be pretty expensive. So in terms of the situational analysis, you'll see that the former President of the United States, Bill Clinton, did visit and was very helpful in procuring antiretroviral therapy, but most of the cases are diagnosed through the public health system. As a result of these interventions, HIV steadily decreased. And we are also in the process of scaling up treatments even further by offering universal antiretroviral therapy to all persons that are HIV infected, and I'll share more with you on that later on in the presentation. Currently, the Bahamas has reported a total of 13,366 HIV diagnoses between the years 1985 and 2014. Of those, 4,710 were documented as AIDS deaths, and the cumulative persons living with HIV at the end of 2014 is approximately 8,630. This gives us a population prevalence of about 2% in the general population. So about 1 in 50 persons are HIV positive in the Bahamas. In 2014, we diagnosed 279 new cases, and the total number of new cases is decreasing. It decreased 25% in the previous 10 years, between 2005 and 2014, and this represented a 66% decrease overall compared to the peak in 1994. The number of new cases decreased in most demographic groups, but there are some exceptions that you should know about. So young persons are disparately affected. The cases doubled in young persons between the ages of 15 to 24 in the last 10 years, and males are also disproportionately affected in that the number of new cases tripled in the last 10 years. I also want to mention a note on key populations. Certain key populations are disparately affected with HIV based on our surveillance and information that we have. And so men who have sex with men is one particular population that is affected, and we have some seroprevalence and biobehavioral survey information that indicates that the rate is actually 20%, which is more than the general, much more than the general population. UNAIDS in 2010 to 2015 had a goal that was a global vision, that we would decrease the number of new HIV infections by 50%. And the Caribbean was one of the regions in the world which did come close to achieving this, and many of the countries did. And you'll see the Bahamas here had a reduction in 52%, as well as some of our other neighbors like Suriname with 86% reduction, Dominican Republic with a 73% reduction, and Barbados with a 66% decline as well. Who is affected by HIV in the Bahamas? It affects persons across a broad demographic group, and males and females have similar trends in diagnosis historically. You see here, this is the graph that showed the overall new infections, but in the blue line, that is the males, and in the red line, that is the females. And so in the beginning of the epidemic, it appeared that more males were infected than females, but this has leveled off, and it's about 50-50 at this point. This is the demographic characteristics of our patients in 2014, and you'll see in this particular year, females accounted for 45%, and that the majority of cases were in the 30 to 39 year age group. AIDS deaths have also declined. Between 2004 and 2014, just around 12,000 persons died of AIDS-related causes in the Bahamas, but the death rate declined from 38 cases per 100,000 persons to 22 deaths per 100,000 persons in the last 10 years. The majority of deaths occurred in males, and incidentally, at the peak, AIDS was the #1 cause of death in the Bahamas, and that has been changed, as we heard from the Director of Public Health yesterday, to cardiovascular diseases and lifestyle diseases. And so you will see that there is a decline in AIDS deaths over the years. So this red line is the AIDS deaths that corresponds with the AIDS diagnosis, and it has also gone down considerably. Prof. Yesterday alluded to the prevention of maternal-to-child transmission. So as a recap for those that weren't there, the Bahamas was one of the first countries to implement zidovudine monotherapy as a standard of care for HIV-positive pregnant women. That reduced HIV vertical transmission rates. There are some variations from year to year. This is largely because of mothers who are lost to follow-up or don't receive antenatal care, and standardly the recommendation is combination antiretroviral therapy for pregnant women. The Bahamas also implemented something called Option B Plus last year. So let me explain. Option A was zidovudine monotherapy, then Option B was combination antiretroviral therapy, but it was based upon the woman's CD4 count and whether or not she was eligible for medication after the pregnancy was over. So Option B was that she had this medication in pregnancy. Once she delivered, if her CD4 count was non-eligible at that time, then the antiretroviral therapy would be stopped. But Option B Plus is a WHO, World Health Organization recommendation that antiretroviral therapy will be continued after the pregnancy, and so we have implemented this from last year. So we know that the rates of mother-to-baby transmission are decreasing. There are some years where we have no cases, but there were 2 cases in 2014. Of the 64 infants exposed to HIV in 2014, 2 became infected, and these were in mothers that did not take antiretroviral therapy or adhere to antiretroviral therapy during pregnancy. So this is a graph of the rates of mother-to-baby transmission from 1995 to 2013, and you will see that before the antiretroviral therapy was available, it was much higher at about 25 cases of mother-to-child transmission, and in 2010 we had 0 cases. We continue to strive for no cases, but unfortunately there will be times when mothers refuse therapy or come late and don't get therapy at a time when it would be strategic and helpful to reduce mother-to-baby transmission. One of the ways in which we monitor the overall care, treatment, and support services that are offered nationally and worldwide and regionally is by the HIV Continuum of Care. It's also called the Cascade of Care, or the treatment cascade. We presented this work done on the Cascade of Care in 2012 at Infectious Disease Society of America last year. So essentially what we did is we did a study to look at the Cascade of Care in the Bahamas. The study background is that we know that antiretroviral therapy reduces the high and early mortality associated with HIV infection. It certainly reduces the progression to AIDS, and it does other wonderful things, like suppressing viremia, which can prevent treatment to contacts. This is called prevention as treatment, and it also reduces morbidity and mortality. So the Cascade of Care looks at patients along every step along the cascade, from diagnosis with HIV to getting on medication and how efficacious is the medication. So it involves expedient diagnosis, linkage to care, good retention and care, appropriate antiretroviral therapy, and certainly adherence and monitoring of viral suppression, because we've got to get to viral suppression, notwithstanding some of the things that can get in the way of that. It's an important set of data for the provision of HIV-related treatment and care, and it's been put forward by some that optimizing care outcomes is related to the cascade at every step of services. The first Cascade of Care that was published was by Edward Mark Gardner in 2011, and what he did is he asked the question, so if you have antiretroviral therapy and it's so helpful, then why hasn't HIV and AIDS gone away? And he essentially noticed that of those persons living with HIV and AIDS in the United States, it was estimated to be about 1.1 million in, is there a pointer? Dr. Chin, you had one, right? Thanks. Wrong way, thanks. So of the 1 million people that were living with HIV in the United States in 2011, only a portion were actually diagnosed. About 75% of persons were aware of their infection, but certainly there were persons that were not aware of their infections. And from there, only about half were engaged in care went saw a provider and stayed in care. And then at that time in the United States too, there were prescribing guidelines for eligible for antiretroviral therapy. So only a portion were eligible for antiretroviral therapy. And overall, the rate of viral suppression was very low, like just under 30%, because they had to get on antiretroviral therapy, stay on antiretroviral therapy, and achieve viral suppression. And so essentially the reason why there are ongoing infections, if we understand the virology of having HIV viremia and exposure, that will cause infections, new infections to contacts. And so a large percent, almost 60% of persons are not virally suppressed. And that's essentially why we may still have new infections. Whoops. So this is another version by the CDC in 2012. So you'll see that, again, only 25% of the persons were virally suppressed in the US overall. But we wanted to know what was the local situation in the Bahamas, and so we looked at the cascade of care in the Bahamas. So we did a retrospective analysis of data that was reported to our National HIV and AIDS program, and we used the information from the Health Information Research Unit for patients newly diagnosed in that calendar year. We looked at the demographics like age and sex, and then we developed the cascade of care using WHO-approved regional indicators. So this was the demographics of our study population. You see most of the patients were female, 47% were male. The median age was 35 years. The age group, 63% were in the age group 25 to 49. And the CD4 counts were low. At the time this study was done, antiretroviral therapy was prescribed for persons with a CD4 counts below 350 cells. And so you'll see that in the last this is row, the mean CD4 count was 349 cells per cubic mil. This is what the cascade of care looked like in the Bahamas. So of the 269 persons that were diagnosed with HIV, 61% were linked to care, and then when we consider early linkage to care, which is within 6 months, 59% were, 28% were retained in care. A third of the patients were eligible based on the CD4 count of less than 350, and we were considering what should we do? Should we scale up to 500 cells as the cutoff for antiretroviral therapy prescription at that time? And then still less than 50% would have been eligible if we had that guideline at the time. 20% were prescribed antiretroviral therapy, and overall only 8% achieved viral suppression. Of those persons who were on medication, 39% achieved viral suppression. We wondered if it was different by gender, and we found that it was not, that the study number was small and p-value was not statistically significant, although there was a trend that more females were linked to care, retained in care. ARV prescribing practices were about the same, but less women in that year had viral suppression than men. Also, we looked at this by age group, and it again was not statistically significant, but again we had a trend. So actually the 0 is, I see that it's run off a little bit, the 0 to 14 is in the blue, and then we have 15 to 24, and then we have 25 to 49, and then we have over 15 in the purple bar. And so it would seem as though those over 50 may have had higher rates of viral suppression, and that the adolescent age group had very low viral suppression, although they were linked to care and retained to care more. This is what our cascade looked like in 2014. So 2 years later, we reviewed this, and viral suppression rates are improving. It went from 8% in the study year 2012 to 19%, and overall of those persons that had antiretroviral therapy, about 40% had viral suppression. What about for the whole population? We use a model called the spectrum model when we do our reporting for UNAIDS every year, and this is a model of what it could look like for our whole population. So the spectrum model, I should tell you, for the people living with HIV is far less than what we have reported through surveillance methods. It's about 6,009. So of those persons living with HIV, 54% were eligible, 24% were prescribed ART, and viral suppression was kind of close to what we found in 2012 at 10%. So we noted that for the continuum of care, attrition was noted at each step of the cascade, and viral suppression was low at 8%. 39% of persons on antiretroviral therapy achieved viral suppression, and that we needed efforts to improve all stages of the cascade to help the overall picture, and that prescribing guidelines at that time, with a CD4 count of less than 350 cells, would make less than 50% of patients eligible, and that we would have needed to scale up antiretroviral therapy. And basically, to improve community viral suppression, we would have to look at all aspects of the cascade in a nutshell. So we wondered, was there evidence for scaling up at that time, and what is the evidence for scaling up? So this is very important. So this is an overview of the when to start antiretroviral therapy studies. And so in the 1990s, there were several ACTG studies that indicated that if antiretroviral therapy was initiated at CD4 counts of less than 200 cells, there was an impact on AIDS mortality and a reduction in opportunistic infections. And then we had the SMART and CIPRA studies in 2005 that indicated that there was a mortality benefit if antiretroviral therapy was started with patients with a CD4 count of less than and equal to 350 cells. There were observational studies that indicated that if antiretroviral therapy was started earlier, it would also impact mortality, disease progression, and non-AIDS events. HPTN 052 showed us that HIV transmission would be reduced for patients. If they were on treatment, they would reduce HIV transmission to their partners, and that would be prevention as treatment. And then in 2015, we had this landmark START trial, and also a trial in Africa that was similar, that gave us proof and evidence that antiretroviral therapy initiation at a CD4 count of more than 500 cells would impact HIV morbidity, disease progression, and severe adverse events. This is a blurb of the abstract for the study that was published in the New England Journal. In the interest of time, I won't go through that. And so you'll see that there was a timeline for antiretroviral therapy eligibility. It was less than 200 cells at first, then less than 350, and then eventually now we're at treat all, and those are our newest guidelines. We are doing that, so this is a snapshot of our prescribing guidelines that were released in June of this year, and we informally implemented this from the spring, from around April. And so we have moved to treat all. However, we are prioritizing antiretroviral therapy for the sickest patients, so those are patients that are symptomatic, those with a CD4 count of less than 350 cells, HIV-TB co-infection, hepatitis B and HIV co-infection, and serodiscordant couples. I talked about option B plus already, and it's similar for adults and children. And then Prof had also alluded to pre-exposure prophylaxis, also called PrEP. And we are in the process of offering that as an additional prevention choice for persons at a substantial risk of HIV infection. And so what this essentially entails is the HIV in a serodiscordant couple, where one partner is positive and the other is negative. The partner that is negative will take a daily dose of an antiretroviral medication containing tenofovir. That's our guidelines. And then there are certain ways that that can be done, like ensuring that the person doesn't get an early undiagnosed infection or develop infection, so on. That's been proven to be very helpful, especially if there's adherence on those medication. Our treatment coverage among those with a CD4 count of less than 350 cells is 52%, but we have some ways to go. Of all people living with HIV, it is 29%. So we hope that that intervention of treating all will increase antiretroviral therapy coverage. And so what is the way forward? Certainly prevention priorities are very important. We know that there are persons that are at risk, like our youth and key populations, and so we will be focusing on preventing infections in those groups. And overall, treatment scale-ups are underway. PrEP is currently being offered. We are currently in the process of expanding HIV testing and certainly reducing stigma and discrimination. So in conclusion, the Bahamas has one of the highest HIV prevalence rates in the Caribbean. There is a decline in reported HIV cases despite increased HIV testing. The HIV epidemic appears to have peaked, and there is a decline in HIV new cases throughout the Bahamas and the wider Caribbean. There is a decline in mother-to-child transmission, as well as the morbidity and mortality of AIDS. Much has to be done to slow the HIV epidemic, but far more needs to be done, and achieving universal access to HIV prevention, treatment, and care is a realistic goal. I thank you. I thank you for the organizers for asking me to present this summary of our epidemic in the Bahamas, and I'll take some questions if you have any.
Thank you, Dr. Forbes, for this comprehensive overview. It felt like I was traveling through a time capsule. Dr. Barrett has a question.
Yeah, I know.
I'm particularly concerned about the reversal, the anomaly where everything is declining, but the 15 to 24-year-old age group. And I wonder if there's an explanation for this and what is going to be done.
Yes, that's a really good question. So as you had referenced, overall, the HIV infections are decreasing in most demographic groups, but we're seeing a trend. It's actually doubled in the 15 to 24-year age, and young men in particular are affected. They're 3 times more affected. You know, I also looked at that when I've done several versions of this. Now, was it in the 90s, were we testing less persons? That's a possibility. Also, there's certainly at-risk behavior. They appear to be affected by HIV and AIDS, especially those that are engaging in non-protected sex and other things like situational sex. And that could have something to do with the increased rates that we're seeing. I also had mentioned in the presentation something you hadn't mentioned, that key populations, like men who have sex with men, have a higher rate, all the evidence seems to show. So special interventions have to be made for this age group. The focus on youth, I didn't mention focus on youth in my presentation because of time, but there was a study done, it was in collaboration with Wayne State University that has been going on for a while, I think more than 15 years, in terms of getting education to youths in terms of decision-making behavior. Certainly, we are making efforts to increase the accessibility of testing and the prevention messages for this particular age groups, and finding strategies to reduce HIV in certain key populations, including prevention, treatment, and cure. But we're also concerned about that. You're welcome.
We can take one more question from Dr. Hannah Hayes.
Dr. Forbes, my question concerns the viral suppression. Even though you're seeing a higher viral suppression rate, it's still low. And overall, your statistics are showing that we have a reduced incidence in newer cases. I'm wondering whether the stigma and discrimination, based on that we're actually getting less persons being reported. Can you comment on that? What do you think?
Okay, so thank you, Dr. Mahez. So the question was, viral suppression overall is low, but new cases are declining. And then, is stigma and discrimination leading to less persons getting tested? Right, okay. So yes, viral suppression is low. How does that look compared to the rest of the world? What I didn't say was that since Dr. Gardner did his cascade, it seems so handy, it's such a great snapshot for the overall model of care, that it is a new UN AIDS goal, that by 2020, all countries are aiming to have 90% viral suppression, 90% of persons diagnosed and linked to care, and so on, and that we have noted that viral suppression is suboptimal pretty much almost everywhere, including the United States. That was the first cascade that we did, and we were concerned that that was low too. Now, why could that be low? In 2012, there were things like eligibility for antiretroviral therapy, which is gone now. Only 30% were eligible, first of all. And so of that number, only a certain subset were placed on medication, 20% when we looked at the graph. I closed the computer. And so of those, even less were virally suppressed. Of those on medication, 39% were virally suppressed. Again, that's not optimal. We would really love to see everyone virally suppressed. There are barriers, though, that get in the way of viral suppression, and they're the human factor. Willingness to take medication, stigma and discrimination. Do I want to come to clinic? Side effects of medication. We are not a medication-taking culture, as Prof had mentioned yesterday. Some people prefer herbal therapy. Denial. many other factors come into play for what can affect viral suppression, and we will have to address those things if we're going to improve viral suppression. We are seeing a trend where viral suppression is going up. How does it relate to the new HIV diagnoses? Yes, even though new HIV diagnoses are going down, viral suppression has to be achieved for each of those persons for their own health and for the overall public health picture of transmissibility. And then the last aspect of your question was, could stigma and discrimination play a role? Was that it? Yes, it can. It certainly plays a role as it relates to people accessing care and things. It relates to all aspects of treatment, care services, and prevention. And so we also have to underscore the need to openly and realistically look at stigma, perceived and real practices, and what we can do to reduce stigma and discrimination, because it certainly plays a role on the whole cascade.
Okay.
I
We'd
think I'm
like to
done.
take one last question from Professor Lane.
The cost of PrEP is actually not very much. It's like a few dollars a month. It's about probably $4 a month for that. We are going to offer it to all persons that are at risk for HIV. So that's men who have sex with men, commercial sex workers, transgender women, there's an echo in here, serodiscordant couples as well, certainly. Yeah. I didn't particularly mention the data related to them, but they are, oh yes, well, I did have them included in our national guidelines that we have sent out, but maybe it was an oversight that it was left out on the slide. We do have some preliminary information on commercial sex workers, but we're in the process of amalgamating and looking at that data closer. So I would like to keep that for another presentation, but I can share it with you in private, yes. But we will offer it to commercial sex workers as well.
Thank you very much.
You're
Can
welcome.
we give her a round of applause?
Please welcome Dr. Veranda.
Right, good morning. What a great talk. I just want to congratulate Nikia. It's an excellent talk, and it's a big topic, and she gave the account in depth. My topic today is age-old. We talk about it all the time, and then we still don't have answer. So it is a perinatal mortality trend in Bahamas. It's a touchy topic. Always we have fight between Department of Obstetrics and Pediatrics. Who killed the baby? No one killed the baby. So, so without delaying, this is a kind of shorter presentation. The aim of my presentation is to kind of bring some awareness actually for the higher people, so that they help us in the Department of Obstetrics and do some more. So without undue delay, I'll just start. So this is the outline. I'll just do the definition, how do we collect the information, summary of observation, and snapshot. This basically is, we have departmental audit what we do, which is, we call it BASSDIN, which is Bahamas Confidential Inquiry in Stillbirths and Deaths in Infancy. And this is, I want to congratulate my head of department for starting this, and he has started doing this in 2010. This is not a national inquiry. This is what we do in our department. And we have been doing this yearly from 2010 and up to 2015. So I have a data of 6 years, and I'm trying to make some sense of the data. So this is from 2010 to 2015. Perinatal mortality rate is a very broad term. It has 2 different components. Perinatal is before as well as after. So, and the definition vary depending upon your country, because anything which consider as a period of viability, so there is whenever there is intrauterine death after the period of viability until 1 week of life, that is considered as a perinatal mortality. And because of that, there isn't really very, there's always the little gray area, which should you include in the perinatal mortality and which should you not. Perinatal mortality is important. The study of perinatal mortality is important for the reason, one, it tells us something about the neonatal care, as well as it reflects upon the maternal as well as antenatal care, and by little overstretch, something about the maternal health and maternal mortality also, although it has been disputed that perinatal mortality has to have any direct correlation with maternal mortality, but we can say at least the access of care and other parameters can be assessed by the perinatal mortality rate. So, to define perinatal mortality, WHO has a suggestion that all countries should report cases which over 22 weeks of gestation. So 22 weeks of gestation is given as can say a point, and or 500 grams. That's the weight. So if there is any birth after 22 weeks of gestation, and if it is 500, then it should be included in the stillbirth record. Okay, so that should be considered as a period of viability, and if the stillbirth, if there is intrauterine death after that, that should be considered as stillbirth. So what does it mean? This anything below 22 weeks, you will consider that as an abortus rather than stillborn. And there is the definition is going up to a neonatal period. So 7 completed days or first week of delivery, first week of your life is considered as an early neonatal period, and that is considered as a perinatal. However, the period of viability is differ or for all practical purposes depending upon your NICU care, depending upon how small babies you could revive in your institution or in your country. Countries use it differently. So we in Bahamas, most of the Caribbean, the yardstick use is 28 weeks of gestation. For us in Bahamas, we are using 24 weeks of gestation. We are not collecting up to 22, but we are using 24 weeks of gestation, and 500 gram remains the same. Now there is a technical thing in the denominator also, because the denominator of stillbirth as well as perinatal mortality is 1,000 total birth. That means stillbirth as well as neonatal death. When you are calculating only neonatal mortality, your denominator is 1,000 live birth. So if you are calculating only neonatal mortality, you will calculate divided by 1,000 live birth. If you are calculating only stillbirth, you will calculate divided by 1,000 live plus stillbirth. If then you combine it, then you get the first denominator. That means if you are doing perinatal mortality, then you will get stillbirth, number of stillbirth, not the percentage, number of stillbirth, number of neonatal death divided by total number of births. So it's always, so whenever, what I'm trying to say, especially for my medical student, that there's always that one number is different, one number is different, and we always wonder why it is like that. So there is an inherent problem with the definition itself. WHO and the other big organization, they try to get, you have under 5 death rates, then you have neonatal death rates. Most of the experts, they suggest the country should collect the data up to complete neonatal, that means up to 28 days or a full month of the life too. So any date from 7 days up to 28 days will be considered as a late neonatal date. Our Department of Pediatrics does collect that data. We do have in the document also, but I have not included that in here. But by extension, we do include that data. We do have that data. So I think I said that already. Perinatal mortality is a key outcome indicator of newborn care, directly reflect prenatal, intrapartum, and newborn rate, mortality of a newborn care. Also proposed as a proxy, I think I said that already, so be assessed in. So I want to put emphasis, this is a voluntary initiative of Department of Obstetrics and Gynecology, Princess Margaret Hospital, that we do that every year. We assign some residents to collect the data, and we compile it, and we generate a report. So the data actually include delivery stillbirths, neonatal deaths in Princess Margaret Hospital. We try and get from Rand Memorial Hospital. Sometimes sometimes we get, sometimes it takes time. And we get from private surgical as well as from doctor's hospital. And the all is compiled. Sometimes there is difficulty in getting those, but we have been doing it consistently. So I tried to, this is the 6-year snapshot, and I tried to compile, put all in one slide, because I just wanted to concentrate on the stillbirth rate now. So we are talking about now, as I was telling you, perinatal mortality is in 2 parts, stillbirth and the neonatal death. So stillbirth in 2010, 11, 12, 13, 14, and 15. So and what you see in the graph is basically monthly, every month. Okay, so some months you don't have, some months you have a lot, and likewise. So it hovered around. So we had the year 2008 or 2008 or 2009, perinatal mortality hovered somewhere around 14. Stillbirth rate was somewhere around 14. Since that time, the stillbirth rate stays somewhere around 12 to 15. Sometimes it goes little up, sometimes it goes down. And then there is another fallacy which I kind of, it's not really something which I'm proud of, but I think you need to know there is a problem in the data entry where we have a very robust system in public sector, which we call it as a perinatal data collection system, or we call it SIP. SIP supposed to collect all the information and enter in the database, and how all this what I'm talking about is ready. Unfortunately, this particular tool is not being used in a proper way. In spite of us having that, there's only one clerk who's supposed to key in all of it, all that. So I calculated that one time, if one clerk takes 15 minutes to key in one patient notes, how much she will do, and in spite of if she don't take any lunch break and keep working 8 hours a day, she still will have backlog of 1 year every year. Okay, so I don't have that calculation here, but I did it one time. So that is the state of affairs. So in the Department of Obs and Gynae, I want to appeal the higher power, because we are lagging behind. The last time when I checked, the data entry was only up to 2007. So yes, that is the truth. If I need any notes of any patient who delivered in 2012, I cannot find it, because it is somewhere in a container port, probably in Freeport now. It used to be in somewhere Carmichael Road, probably in a Freeport now. Anyway, so that's it. I will try. Okay, so then according to the facility, if you have Princess Margaret Hospital and okay. The stillbirth rate according to facility, I mean, it's very obvious that your Princess Margaret Hospital rate is little higher, but you will be surprised that sometime your Rand also, and at 1 year, I think was it 2000, even Doctors Hospital had, that was 2013. So they had little high rate. Because the reason I wanted to the pool analysis is because considering our delivery rate is so low, because if you go in the population statistics, we are not increasing. We are not increasing in Bahamas. We talk about family planning and we talk about crowding, but the total fertility rate, national fertility rate, is only 1.9. To sustain any population in this world, you have to have at least 2.1. Bahamian total fertility rate is 1.9. So the birth rate isn't really increasing. So we are there. So that's why I thought it is necessary to do a pool analysis rather than just keep doing yearly. So the causes of stillbirth. Most common maternal disorder which is associated with stillbirth is hypertensive. I included all of that, so hypertensive disorder, that is chronic hypertension, preeclampsia, eclampsia, all of that, and which the complication of that is abruption. Most of these patients, they will come an abruption, and I don't have any pie chart here, but every year somewhere in between 72% or 74%, I mean, my average is 73% of the stillbirths, they are macerated stillbirth. That means I can't do anything. If the person come and the baby is dead already, what else we could do? So we have to do something before those things happen. So again, we talk about the general health and awareness and antenatal care, all of the 10. I mean, the overall Bahamas, no antenatal care rate is 10%. In stillbirth, in some years it is 14%, some year it is 13%. So the overall no antenatal care. When I mean no antenatal care, that means I don't mean 1, I don't mean 2, I mean 0. 0 antenatal care is 12%. So you do have, and then obviously there is some data entry flaws that nothing is noted, so you have that at a higher level. But the main crux, if you want here, so these two. So you have hypertension, abruption, and this was placenta previa, and then you have here, what you have? I don't have there somewhere preterm labor. Yeah. Previous miscarriages there, but previous miscarriages, I mean, because it was there, but I don't really think it does have, I have a statistical significance there, but I don't think it does have any clinical significance. So in now going to early neonatal deaths now, early neonatal deaths, again, it is the first week of life is considered as an extension of your intrauterine environment, and that's why we always fight Department of Pediatric. They will always try and find out what we didn't do wrong, what we didn't do right. And I think there is a need of some more introspection, and there is a need of probably a joint committee to actually look into that. So now if you see the early neonatal death rate is, again, this denominator here would be 1,000 live birth and not the total birth. So it is 7.5 per 1,000 live birth, 12.3, and so on. Common causes of early neonatal death: severe prematurity, that is number one. That doesn't mean that the older baby don't die. I mean, the bigger babies don't succumb. Actually, that is another different issue. I don't want to go in there. That's another issue, the topic of discussion. But the most common cause of the early neonatal death is severe prematurity, and the complications secondary to that. You have perinatal asphyxia, then congenital anomalies, infection, PPHN, which is persistent pulmonary hypertension, pulmonary hemorrhage, pulmonary consolidation, and intracranial hemorrhages. Meconium aspiration syndrome, a few years ago, maybe in my early days, we did have a great number of meconium aspiration, but it is obvious from the data now that Department of Pediatrics and Department of Obstetrics are they working in hand, and we don't really see that many cases of meconium aspiration syndrome because it's on the lower side. So just to give a little snapshot, where are we now? Again, I don't claim that all these figures are completely correct, neither the other Caribbean nor ours, because again, I say there is always a deficiency in data collection. But we shouldn't really keep blaming ourselves that we are really bad. I mean, we always have been lambasted that the babies are dying and doctors are killing baby. That's not truth. On the contrary, it is showing a little decline in last couple 1 or 2 years. But we can't really say anything unless we keep continue the monitoring and try and improve us. Challenges, I think I told about already, the definitions. We have challenge in the defining the term itself. There is a data collection. There is a duplication of data. We collect data, which is manual data, then the clerk collect data, which goes in a computer, and then there is a coordinator, which is maternal and child health coordinator. She or her staff will come personally and collect the data, and we will have 3 different sets of data. And I personally don't know which one go where. And I feel if we use only SIP effectively, we can take out. We have inadequate clerical, as I explained already, and pathological support. There was only one pathologist who herself was interested in doing autopsies. I didn't include autopsies because that's another big topic. Who took upon herself to do autopsies, and I heard she's retiring now. So I don't know what will happen to our babies. I mean, we will not really have any pathology report. So we need pathology support. What else? As I say, it's a big thing, mobilization of resources at national level. Bahamas should become a national audit rather than a departmental inquiry, and we need quality control of reporting. I thank for the organizer, and thank you very much.
First up, we have Dr. Zanel Belang, who's a former resident in the pediatric department. She's a pediatric resident that has completed her DM. She's going to give us a talk on retinopathy of prematurity at the neonatal intensive care unit of the Princess Margaret Hospital. Let's welcome her.
Morning. My name is Dr. Balang from the Department of Pediatrics. Today I'll be presenting a study we did on prevalence and risk factors for retinopathy of prematurity. So the WHO estimates that there are 1.4 million blind children worldwide, and out of these 1.4 blind children, 2/3 of whom live in developing countries. Additionally, it is estimated that 50,000 of these cases are accounted for by retinopathy of prematurity. So retinopathy of prematurity was first described by Terry in 1942, and what it is a developmental vascular proliferative disorder that occurs in the retina of preterm infants with incomplete retinal vascularization. So just to give a background, we're currently experiencing a 3rd epidemic of ROP, and this is based on various reviews of trends in global epidemics and prevalence patterns. Initially, it was described, like we said, in 1942, and the era between 1940 to 1950 was the era following the pre-Nicky era, where care of preterm infants was very liberal. Little was known about use of oxygen in resuscitation of this infant. So it was later found that liberal use of oxygen is associated with retinopathy of prematurity. So as such, adjustments were made in clinical practice, and we saw the numbers dropping. Again, in the 1970s, we saw another spike in the prevalence patterns, and this is because there were now advances in the field of neonatology. There were now use of mechanical ventilators, surfactant therapy, and so there was increase in survival of infants. And from the 1980s to present, we're currently witnessing what is referred to as a 3rd epidemic. And this is because of developing countries or middle-income countries adopting NICU practices. So they're resuscitating smaller infants, but they're doing this with less than optimal care. Sometimes they don't have access to ventilators or medication. So what we see with this is that there's increase in survival rates in infants who are not getting optimum care like in first world countries. So these countries are now reporting higher rates of retinopathy of prematurity. Should I just continue? Okay. So my slides are not moving, even on the screen. So, it's frozen. It's not moving on my screen. Okay. So where were we? We were talking about the highest rates of blindness from ROP being reported in countries with infant mortality rates between 9 to 60,000 per 1,000 live births. And here in the Bahamas, we fall in that high-risk category because you can see that in 2013, we reported infant mortality rate as high as 22.7. What has happened with NICU services here locally is that we have continued to expand. We introduced level 3 NICU officially in 1997, and since then we have increased in capacity in terms of acquiring new technology, acquiring medication, training of more staff, as well as we now have a 64-bed NICU unit. And it's important that as we continue to expand, we review our outcomes, because preterm infants represent a special population that has morbidity and mortality that's special to them. And ROP is one such outcome from premature infants that actually has recognizable risk factors that if they're identified early can be modified. So the aim of the study was to determine the descriptive epidemiology regarding retinopathy or prematurity in a cohort of infants admitted to PMH NICU in Nassau, Bahamas. And the objectives were to determine the frequency of ROP in infants at NICU because different regions have reported different numbers. And like we said, this is because of variations in level of care available. We also wanted to identify the risk factors associated with ROP, particularly to our population here. Another thing we set out to do was to ascertain the occurrence of ROP in a sample representative of the population outside of the screening recommendations. So currently we're screening based on weight as well as on birth weight as well as age. And we're following recommendations from the American Academy of Pediatrics and Ophthalmology. But there was a study that was done in 2013 in China where they looked at 2,800 babies. And from their study, they found ROP in 14% of infants who, if they had used the UK screening guidelines, would have been missed. And they additionally found 21% of ROP in patients that, if they had adhered to the US screening guidelines, these patients would have been missed. So we thought it would be important, seeing as we're saying that these outcomes are different in middle-income countries, it would also be important to see how much we are seeing outside of the population recommended for screening. So this was a retrospective study. We looked at 99 preterm infants from the period of January 2014 to September 2015, and all the infants were examined by an ophthalmologist. So upon admission to NICU, every baby is subject to weighing, length measurements, as well as during their NICU stay, they would receive medical care for their various medical conditions. At the end of their NICU stay, everybody has a discharge summary, and during the time while they're in NICU, at the timing that's determined from rounds by the consultant neonatologist, patients who require eye exam are identified and they're further examined by an ophthalmologist. So for this study, we captured the data from their discharge summary as well as the eye findings from the ophthalmology. And these are the data, the variables that we extracted from this study. With regards to oxygen exposure, there are various studies out there which link ROP and oxygen, and it's not just duration of exposure, it also covers fluctuations in oxygen FiO2. But for the purpose of this study, we were only able to capture the total duration of oxygen exposure. We also looked at sepsis. We looked at overall accounts of sepsis, as well as sepsis of bacterial etiology and fungal etiology. And then we also looked at culture-proven sepsis versus clinical sepsis. And in this study period, we included all the infants who were eligible for studying. We started off with about 196 infants who would have fit criteria for screening, but then some died prior to being screened and some were discharged prior to being screened. We actually had 39 patients discharged prior to being screened who were actually eligible for screening, so they were excluded from our study. So in the end, we ended up with 99 patients to include. And the distribution of these 99 patients, you see, was males and females, and there was no statistically significant difference in the ratio of males to females, as well as by gestational age and gender, there was no, and birth weight, there was no statistically significant difference. And we looked at eye findings of these 99 patients. So when describing ROP findings, it is described by stage as well as zones. But for the For the purposes of this study, we just wanted to see the presence or absence of ROP. And from all the eyes examined, we found that 28.3% of the patients in this study had some stage of ROP, and by gender, there was no difference, there was no statistically significant difference. The rest of the patients in this study, 65% of them had immature retina, 5% had mature retina, and we had 2% who had cataracts, which is actually really one patient. And even though we didn't go into detail about staging and zones, out of the 28% who had ROP, majority had stage 1 disease. So for the patients who, the other patients who were in the study who had ROP, only 3 of them eventually required medical intervention with avastatin, and of those, 1 of them subsequently required cryotherapy. So we also looked at the ROP status based on the variables like gender, gestational age, and birth weight. And we found that when looking at birth weight, ROP occurred more in the younger patients. So in the patients who were birth weight less than 1,000, we found that there was a statistically significant different association with ROP and smaller infants. And this is logical, and it follows what has been described in the literature. And it also follows based on the pathophysiology as well. We looked at duration of oxygen therapy, and the relationship between oxygen and ROP has been well documented, and we know that it is not just the exposure to oxygen, it is also the amount of oxygen, the percentage, the FiO2, and the fluctuations in O2 saturations. But for this study, like I said, we only looked at the cumulative exposure to oxygen therapy, and even with that, we were able to, so the patients here, denoted 1, are the ones who had ROP, and we're able to see that the median exposure to oxygen is actually higher compared to the patients here, denoted 0, who did not have ROP. So it is a multifactorial disease, and we had looked through the charts to see which risk factors the patients possess with ROP. And looking at all of the risk factors, we found that with sepsis overall, there was no statistically significant association with sepsis and ROP. But when we further dichotomized the data to look at bacteremia and candidemia, we then saw a statistically significant relationship between the presence of candida and the occurrence of retinopathy or prematurity in our population. And this has been described in the literature as well, and it's consistent with other findings out there. Another risk factor that we found to be significant was the relationship between duration of oxygen therapy and the occurrence of retinopathy or prematurity. So these here are the cases who had ROP and oxygen therapy. And you can see that when we increased the amount of days exposed to oxygen, the amount of cases we were reporting increased as well. Again, this just denotes, again, the patients who had ROP with longer duration of oxygen exposure. So basically from these findings, we found that there was a significant relationship between candida infection, birth weight, duration of, and duration of oxygen therapy. The other risk factors that we studied, we didn't find a significant relationship. We did a binary multiple logistic regression analysis of all the risk factors, and in the end, we found that these were the two most important, these were the two parameters that emerged to have significant association or to carry a risk of retinopathy or prematurity. I just want to draw your attention to the odds ratio here for the total duration of oxygen exposure. When you look at it like that, it is a little bit misleading because it doesn't look as high, but this oxygen here is defined as a time factor. So when you start off, this is at time 0. So day 1. And as you go on with more days of oxygen exposure, this OR actually increases, such that by the time you get to day 4 of oxygen exposure, the odds ratio is about 4.25. And by the time you get to day 10 and day 20, it just even increases more. And regarding occurrence of ROP outside of recommended screening population, in our population, we had 22.2% of patients who were screened who were actually outside of the recommended screening population. And we found that within those 22.2%, 13.6 of them had retinopathy of prematurity. And this was either they exceeded screening recommendation either by gestational age or by birth weight. So in conclusion, we found that the estimated prevalence of ROP in PMH NICU was 28.3%, and this is just the presence of ROP. And we found that in our population, the most significant risk factors was candidemia, prolonged use of oxygen therapy, and birth weight. And we also found ROP in 13.6% of patients outside of recommended screening population. The limitations for this study is that it was relatively short with a small sample size. The patients were examined by different ophthalmologists and therefore may have been subject to inter-observer bias. And also we lost, if you remember earlier, we lost 39 patients who met screening criteria but were discharged prior to screening. And also in some of the records we had data that was missing. So we recommend further studies with a larger sample size to explore issues identified which were beyond the scope of this study and or limited by sample size. We have also found that the association between duration of oxygen and candida sepsis was significant enough, and therefore healthcare workers should be sensitized to this findings to help guide practice, including encouraging judicious use of oxygen as well as discouraging prolonged use of antibiotics where necessary. We should implement a follow-up system to decrease the amount of patients who are lost to follow-up and thus not screened for ROP. And also it would be worthwhile to review our screening criteria for our population, recognizing that birth weight carried a slightly higher association than gestational age. Thank you.
Do we have any questions? Oh.
For the babies that were screened who are out, who did not meet the criteria for screening, we determined this factor so, high risk. Okay. So to repeat Dr. Chisholm's question, for the babies who were screened who were outside of the screening recommendations. So these patients are identified by the consultant neonatologist, and those would have been patients who would have experienced either prolonged use of oxygen. So it was patients who we deemed from their risk factors that they were at higher risk, even though based on their gestational age and weight, they did not meet screening criteria. They had, right, so the risk factors that we identify.
You mentioned your finding of the oxygen duration exposure as a risk factor. Did you also look at the amount of oxygen given by your school level for these patients? Was it 30% or were these babies 100% for a long period, and also any association with EPD problems?
Okay, so Dr. Menz was asking about the oxygen exposure and the amount of oxygen they were exposed to. So for this study, we were not able, because of difficulties with documentation and the fluctuating levels throughout the day, we were not able to capture that information, but we did recognize it as a limitation for the study. But however, even without capturing it, we were still able to demonstrate that that exposure of any amount of oxygen or duration was still a significant risk factor. Regarding respiratory distress syndrome, BPD, sorry. From this study, the patients, we didn't find any statistically significant association, but we did look at it as a risk factor.
All right. In the interest of time, we're going to move on. Thank you very much, Dr. Beilein. All right. It's always encouraging when we have medical students who are also taking part in research. And our next speaker is a fourth-year medical student, Ketavia Balfour, who will be speaking to us on keeping the score on child survival in Trinidad as we shift from Millennium Development Goal 4 to Sustainable Development Goal 3. Please welcome her.
Good morning. My name is Katavia Balfour, and I'll be presenting Keeping the Score on Child Survival in Trinidad as we shift from Millennium Development Goal 4 to Sustainable Development Goal 3. This Year 2 research project was done at the St. Augustine's campus by a team of 9 students, supervised by Dr. Camille Mungru, Lecturer of Community Health. Under 5 mortality, a topic that has increased in popularity since the World Summit for Children in 1990, can be seen as a potential indicator of human development around the world. This is because accurate statistics on child mortality rates not only identify the leading causes of death for children in a particular region, but can also assist in developing possible solutions and/or recommendations to further reduce the rates. The Millennium Development Goals are quantifiable targets that allowed progress assessment. Millennium Development Goal 4 was a target of reducing under 5 mortality by 2/3 between 1990 and 2015. These have been replaced by the Sustainable Development Goals, effective until 2030. Sustainable Development Goal 3 deals with ensuring healthy lives for all at all ages. And in regards to child survival, the targets are to reduce neonatal mortality to as low as 12 per 1,000 live births, and under 5 mortality to as low as 25 per 1,000 live births. The objective of the study was to determine the factors associated with child mortality during the transition from Millennium Development Goal 4 to Sustainable Development Goal 3. This study design, it was a retrospective descriptive analysis. It targeted 2 major hospitals in Trinidad, the Mount Hope Maternity Hospital in the north and San Fernando General Hospital in the south. Ethical approval was obtained from the university and all other relevant stakeholders. The aim was to review all child under 5 deaths from July 2013 to June 2014. The study took place in 2 phases, the first of which included identifying all the reported deaths from the Central Statistical Office for our target period, and this data was used to locate the medical records of all the deaths. Moving into the second phase, we reviewed the medical records of all of the cases, and we extracted clinical details surrounding the birth and death of each child, and we used it to create a database, which was stored and analyzed using SPSS version 16. The data collected at each phase, during phase 1, we got the name, address, and hospital, and phase 2, we gathered the gravidity, parity, maternal age, category of death, 1-minute APGAR score, and birth weight. Our findings: 345 deaths were identified from the Central Statistical Office, and we calculated an under 5 mortality rate of 18.8 per 1,000 live births for our target period. 295 of these 345 deaths occurred at the 2 institutions that were included in our study. However, we were able to review 52 of the 142 medical records from Mount Hope Maternity Hospital and 41 of the 153 medical records at San Fernando General Hospital, giving us a total of 93 cases for review. Our findings: for the purposes of this study, we classified perinatal period as 0 to 7 days, neonatal as 8 to 28 days, infant as 29 days to less than 1, and under 5 would be from 1 to younger than 5. And we found that the greatest proportions of death were recorded for the perinatal period at 43%, followed by infant at 29%, neonatal at 27%, and under 5 at 1%. For the 1-minute APGAR scores, the highest proportion of the cases, 39% to be exact, were in babies with a value of 9 to 7, followed by 34% valued at 6 to 4. 17% of the cases had a value of 3 to 0, and the data was missing for about 10% of cases. We also found that mothers in the age group of 15 and 19 had the highest rate of under 5 mortality, a rate of 1.6 per 1,000 live births. Also, women in their first pregnancy recorded a 25.6% of under 5 deaths and 27.9% for women during the second pregnancy. Our findings on birth weight: 58 of the 93 cases were recorded at a birth weight less than 2,000 grams. 31 were in the range of 2,000 to 4,000 grams. 2 were above 4,000 grams, and this data was missing for 2 of the cases. The cause of death, these were classified using ICD-10 codes, and we see that the most common causes of death were short gestation and low birth weight, accounting for 47 cases, which was 51%, followed by septicemia and other respiratory conditions at 25 cases and 27% each, closely followed by respiratory distress syndrome, which accounted for 24 cases, which was about 26% of our sample. Our conclusions, we identified 345 deaths from the Central Statistical Office and report an under 5 mortality rate of 18.8 per 1,000 live births for the period of July 2013 to June 2014. When we compare this to the 1990 under 5 mortality rate of 33 per 1,000 live births, we see that although Trinidad did not meet the goal of a 66% reduction, there was a significant decrease of about 44%. We found that APGAR scores were not useful in identification of the babies that were most vulnerable, and results display that short gestation and low birth weight and babies born to adolescent mothers were the main contributors to under 5 mortality. The limitations of the study was that information in the medical records were handwritten and difficult to discern in many cases. There was missing information from the available records, and also medical records that were being used as evidence in ongoing legal matters were inaccessible. Recommendations. The frequency of under 5 deaths can be reduced by continual maternal education for pre- and postnatal care, increasing the number of neonatologists in the country, as well as increasing the aptitude of neonatal care in Trinidad by investing in equipment and technology to aid in the rehabilitation of sick children. The next steps would be to raise public awareness about the causes and prevention of infant deaths, to partner with government officials to find correlations in relevant research, and to improve data analysis. Also to encourage first-time mothers to receive sufficient information on infant care and parenting. Here are my references. Thank you for your attention.
Thank you very much, Ms. Balfour. Do we have any questions? Well done. Thank you.